for this panel discussion. One of them was the importance of obtaining a second opinion for the diagnosis of cancer. I think we have addressed that. Anyone with cancer should get a second opinion from an academic medical center where research is being done in those cancers. And I think it is important that if you have a physician that says, oh, you don't need a second opinion, you need to find a new doctor. Absolutely. The other issue was the role of complementary and integrative medicine. Janine has joined us. Please, if there are questions about that. I think one of the questions I get asked all the time, and I don't expect you to answer, I'm throwing these out right now, is does stress cause cancer? Every time my patients will say, I had such a stressful event and I got cancer. So Janine's going to try to address that. And you touched on it a little bit. Are there certain foods that I should not eat? I am constantly having patients come in with vials and vials of vitamins and supplements from the natural stores and overdosing actually on some vitamins. I think that's an important thing to address. One of the other questions that, what is myelodysplastic syndrome? We talked a little bit about that. It's a terrible complication of being overtreated and overtreated and overtreated with, I know Dr. Schuster said chemotherapy is good. I agree with him. It does cure patients. There is no question. But I think what we learned from physicians in the past is that they overtreated these patients who really could live a long time without treatment. So it's when do you need that chemotherapy? That's the important aspect. And the last question here is a question on transformation. We did talk a little bit about that, just if you have any more comments on that. And then a clinical trial, is it right for me? A clinical trial is right for any patient at any time. And you see what they can do in Germany. We haven't been able to do it yet in the United States. To accrue thousands of patients to a clinical trial in a matter of a couple of years. All right, that's just some of the things that we should address. Yes?
Yes, I just want to thank everyone for putting this on. It's great as a patient to have this chart at our disposal. Thank you so much.
Thank you.
I wanted to ask the question of the panel about second-line therapy and radioimmunotherapy. I know that wasn't really talked about much today, and I'd like to find out more about how that works and what the outcome is and what the recurrence is after that second-line treatment. Thank you.
So I guess I'll start. So radioimmunotherapy is one of the therapies that we did not really address much other than it's mentioned in Betsy's talk at lunch. It is an active and very viable therapy for patients with follicular lymphoma. It is probably the most underutilized active therapy for patients with follicular lymphoma. Like what I said for autologous stem cell transplantation, the earlier in the line of therapy that radioimmunotherapy is used for follicular lymphoma, the more effective it is. And actually, Dr. Gregory's work was the one that she's the one that showed that most conclusively in a paper some years ago. It is a therapy that produces responses related to how soon in the line of therapy it's utilized. In the studies that first led to its approval, both for Bexar, for I-131 tostatumumab, or for Zevalin, Yttrium 90, ipilimumab, Tiaxtan. I guess I did say it twice today. But both of those therapies have response rates that are more similar than they are different, with response rates in the 20 to 30% complete response rate and overall response rates in the 40 to maybe as high as 60%, depending on which studies you look at. There also is a potential role for each of those therapies, maybe, and more conclusively shown for Zevalin as a form of consolidation after upfront therapy. And that's another place where they also are underutilized as a way of trying to keep the follicular lymphoma away for a longer period of time after chemotherapy is given for first-line therapy.
So I have to comment that Rush has probably had as much experience as any other institution in the use of radioimmunotherapy. We've treated over hundreds of patients with radioimmunotherapy since, and involved in the very early clinical trials going back to 1999. It is a treatment that is easy. It's day 1 and day 7, and it's done. There are no side effects while you're getting that treatment. It's an infusion of a drug like rituximab, and then a little bit later they give a test dose of rituximab attached to a radiation, and so a lot of patients refer to it as liquid radiation. It's given intravenously. That first day of treatment is over in 3 hours. You have someone come and scan you from our nuclear medicine department to make sure that you're not radioactive and that you're safe to go home. It is a very safe drug. Patients used to be scared because we had to Geiger counter them and they were afraid they were going to be radioactive. That's not an issue. The delay in drop in counts is later than chemotherapy. The low point of the counts is 6 weeks after the drug is given, and the recovery of the drug is 13 weeks later. When it's used earlier, I've never had a patient get a low white count that needed any address. I've never had them get a fever, and I've never had them have any bleeding from low blood counts, low platelets. The earlier clinical trials, it was used after patients had failed many trials. And even those patients that responded had a complete remission. I have 12 patients now from my original trials back in 1998 that are in remission for 12 or more years with 1 single week of therapy with radioimmunotherapy. It is underutilized because the oncologist doesn't give the medicine. That 1 week of treatment and that money goes to the nuclear medicine doctor. It is much easier for a physician in his office to give rituximab every 3 months for 2 years at a lot more expense than to give 1 week of radioimmunotherapy. And I could go on for hours, but I'm not, because it is an underutilized form of treatment. You have to have less than 25% bone marrow involvement, so you have to have a bone marrow done. You can't have a lot of tumor in the bone marrow, and your white count and your platelets have to be relatively normal. And that's pretty much the indications, and it was approved for relapsed follicular and indolent lymphoma, but more recently it's approved for frontline use after chemotherapy. And so what I am doing now with many patients, we do 12 treatments a year. I do 1 to 2 a month. I do abbreviated chemo. I don't do 6 cycles of chemo. I'll do an ARC chemo, and then I will consolidate with 1 week of radioimmunotherapy. And we have at least a dozen patients right now that have had that right as frontline treatment that have remained in remission for more than 2 years. And that's early because that's when we just started doing it. So it's very underutilized. Any other comments?
May I just add one thing? There's not really a whole lot of very good information about radioimmunotherapy out there, but if you go to my website, which is betsydeparry.com, there's a whole section on there of radioimmunotherapy. I've got links to studies, links to articles. I did an interview with Dr. Kamensky, who, as I mentioned, is co-developer of Bexar, one of the 2 RIT drugs, almost 2 years ago. There's a transcript on there. And he really talks about it at great length. It was an hour interview.
The Zevalin website also has a great deal of information. One of my patients has done a whole story on the Zevalin website. So the information is out there. You just need to know where to find it.
It is underutilized, and it is also very spectacular. We have a clinical trial that we started in 2006 for patients who've had autologous stem cell transplants that had residual or recurrent disease after transplant. It was a dose escalation study, so the patients that we have the longest follow-up on got tiny doses of radioimmunotherapy. And I have to tell you that we have patients in their 5th year who had disease that resisted high-dose chemotherapy that are in remission after low-dose radioimmunotherapy with Bexar. It's capable of inducing very prolonged remissions. I dare not say cure. We're not allowed to do that. But if you look at patients that are in remission, or those that have complete responses, and they're still in a complete response at 1 year, the probability of remaining free of disease for more than 5 years approaches 50%. Yeah, if you're in remission at a year.
Unbelievable.
It is truly amazing.
And actually, we will have 3 trials for radioimmunotherapy. We're using Zevalin right now, which is the ibertumumab tioxetan. It's a little bit easier to give than Bexar, and it is now that company that is actually sponsoring these 3 clinical trials. One of them is our chemo up front for advanced follicular state, patients who need treatment, frontline treatment for follicular. And the choice of the our chemo chemo is either R-CVP, R-CHOP, or R-bendamustine Rituxan. So again, you've learned that not one of those chemoimmunotherapies is better than another. I mean, maybe one has less side effects, et cetera. And then after they respond to the R chemo regimen, they will be randomized to radioimmunotherapy consolidation for 1 week of treatment or 2 years of Rituxan maintenance. Because that's the big argument out there. Can you do 1 week of consolidation with radioimmunotherapy after you've had R chemo, or do you have to do the 2 years of Rituxan maintenance, which was discussed in the PRIMA trial? So you have to compare the two, and that's being done. The other trial that's being done is in diffuse large B-cell, and we know that's a curable cancer, cured by R-CHOP. But we know that there are sub-patients who aren't cured with it. So another trial that they're looking at is R-CHOP with Zevalin consolidation if the patient gets a good remission versus R-CHOP alone, which is the standard of care. So there are many clinical trials out there. We happen to have several of them here at Rush, and there are many going on throughout the country. And that trial, the two trials I just mentioned are global. They're anywhere in the world. So they'll be opening soon. Yes?
I just had a question. How soon after chemo can you get the radioimmunotherapy?
6 to 8 weeks. You have to recover your counts.
Okay.
We have a couple questions, one from the UK, one from Colorado, one from California, all about RIT. And they want to know when is the best time, or what setting is the best setting for RIT, the most effective, and whether receiving prior rituximab treatment actually adversely impacts the effect.
Would our panel like to address that?
I mean,
Earlier is better.
Earlier is better for everything, okay? Every treatment we have, when applied earlier on in the course of the disease, the success rate and the duration of response is better. So, like everything else, that applies to radioimmunotherapy. Patients that are Rituxan resistant or refractory, like that fail to respond to Rituxan or progress shortly after receiving Rituxan, have a lower response rate than patients who are not Rituxan refractory. So giving Rituxan does not necessarily generate Rituxan refractoriness. So to answer your question, does giving Rituxan to somebody make radioimmunotherapy less effective? The answer is not if they're Rituxan sensitive. It seems not really to matter much. In fact, for Zevalin, you give a dose of Rituxan before you get the radiation on the same day. So, and it seems not to interfere. But if you are Rituxan resistant, you can expect lower response rates.
The last question about RIT was, there was some data out of Switzerland last year, was presented last year, about that the benefit of RIT to chemo-resistant or chemo-refractory patients was greater than to others. Can you say something about that?
I'm not sure I know that study. Dr. Kaminsky's original trial, which was 60 patients, a multi-institutional trial, looked at patients who were very heavily treated and they were chemo refractory. And their response to the last chemo was something like 38% with only 3% complete remissions. He used radioimmunotherapy with Bexar in those patients and had an overall response of 60% and 25% complete remission. So it works in patients who failed chemotherapy and rituximab, and patients it did not even, they didn't even have a good response to their last chemotherapy. So it works in chemotherapy refractory patients. You just have to make sure that the patient selection is good.
And it still works in Rituxan refractory patients too, just not as well. In fact, the label, since we tend to be hung up on labels today, is for patients
Rituxan refractory.
It's included in the label. And we all know what labels mean.
Another question was?
We have another question.
Okay.
This one from Australia. These are from all the Facebook groups. They're
Okay.
chatting and giving us questions. This was actually a question for you, Dr. Schuster. And it has to do with the CAR-T19 trials. And they want to know, what has progressed since that article in the New England Journal of Medicine last year, where it was just small.
Yeah, well, 3 patients were reported, and there's been about another 4 treated since that article. So the trials are ongoing, and we expect in the next year or so to sort of have a much more revved up support system for the clinical research and get the trials moving a little more quickly. It's slow going, but when you're doing really early phase work like this, you have to go slow. So as we're learning about the toxicities and some unique findings related to this therapeutic approach, you have to go very slow at the beginning.
But the trials are now opening to other forms of, other subtypes of
right now,
lymphoma.
we've only treated CLL. Okay, the plans are that there will be a mantle cell and follicular lymphoma trial. We initially were thinking it would have been this summer past, but you know, as I said, things are unfolding a little more slowly than we had originally planned. But there's still the next trials that are planned because they target the same antigen, CD19, which is present in CLL. It's present also in mantle cell and follicular lymphomas.
Since these patients have had additional time, since the article was published last year, how are the T cells still as persistent, and how does that affect their overall immune status?
The data that I can tell you is that at last look, the last look I'm aware of, there's evidence that there's persistence of the T cell clones. Also, there's hypogammaglobulinemia, meaning your normal antibody levels drop down because your normal B cells are taken out because they have CD19 on them too. So you need gamma globulin replacement in that situation, which is not that big a deal. I mean, it's something we do all the time in patients with lymphomas that are immunosuppressed for other reasons.
Thank you. Janine, would you answer the questions that we posed at the beginning about nutrition, vitamins, supplements, the other question of stress causing cancer?
Well, certainly, from the literature, there is a tremendous amount of literature looking at the role of stress and how it affects our HPA axis, the kind of the stress response, the sympathetic nervous system, which is our stress response, versus the parasympathetic, which is our relaxation response. And certainly, Janice Keikolt Glazer out of Ohio State, she did kind of some of the preeminent research looking at the role of stress and immune functioning, where individuals that were under long-standing chronic stressors, actually they find that their immune systems are compromised. Now, the definitive research on does stress cause cancer is not there in humans. They look at the role of stress, and certainly it can compromise our immune system. And when individuals are certainly facing a disease like cancer and undergoing treatments that also then add to compromising stress and compromising their immune system, anything that we can do to support their immune system by having people feel like they have more control, taking an active role in their health, and certainly how people cope. I think that's the other thing we have to look at. People cope in a variety of ways, and so the research has been done on looking at not only our physiological response to stress, but also then how do we respond, how do we cope with that. And so I think it's very difficult to find any definitive that stress causes cancer. So I don't think the data is there that would support that in particular. Certainly stress does play a role in our overall health, because typically when we're stressed, we may cope by not eating very well, not sleeping very well, not taking care of ourselves by being physically active, all of those things which we know support our health in general. So that's a kind of Reader's Digest version of the stress literature. There are books written about this. In fact, Carolyn Aldwin wrote a book that was published in 2007 about stress, coping, and development of kind of health-related issues. And she literally reviewed all of the literature that was out there. And so there is no definitive research that says stress causes cancer, but it certainly may play a role in kind of compromising our ability to fight off those types of things. The role of nutrition, I think there is more and more being learned in nutrition. There's more and more research being conducted. There's actually an entire field out there of nutrigenomics that is you're going to hear more about it, I think, as we go forward. And it looks at the genetics of the food we eat and our own personal genetics and how those two go together in the development of health and diseases. And I think we're going to hear more and more. There's a gentleman at the NCI that's doing a lot of research in nutrigenomics and looking at how the role of genetics of the food we eat versus our own genetics and how they go together to keep us either healthy or kind of make us more susceptible to particular diseases.
All right.
And I do think that you had commented about the vitamins and the supplements, and I think people have to be very careful, especially with some of the things that you find at the health food stores, because one has to keep in mind that many of those substances aren't regulated. Andrew Weil and, oh my gosh, I'm blanking on his name. He's a medical oncologist out at the Osher Center in San Francisco. They wrote a book and published a book on all the research in integrative oncology, including what does the literature say, what does the research say on taking these types of supplements or herbal medicine and how it may interact with if you're undergoing chemotherapy, and some of that can actually make you more susceptible to damaging effects. So you just have to be very careful with some of this because it's not regulated. Some of the Western herbs are not regulated by the FDA, and so you never know what you're getting.
Right, and please tell your doctor. Sometimes we forget to, we'll say, are you on any medication? Our patients will say no. We know that over-the-counter medicines sometimes are not considered medications. You need to share with your physician everything you're doing. He's not going, if he's a good physician, he's not going to poo-poo it and make fun of you, but he will tell you that perhaps all of our healthy cells need vitamins to grow. Cancer cells probably need vitamins to grow too. So if you're on vitamins and we're giving you something like methotrexate, it may be counteracting the chemotherapy. I just tell all of my patients to stop any supplements when I'm treating them, and I think that's probably a wise thing to do.
I think that there was some literature, I think it was out of Memorial Sloan Kettering, looking at, certainly people are interested in high dose antioxidants, and I think when we are healthy, certainly antioxidants, we hear a lot about them, the foods, all the foods that have antioxidants and anything that we can do, but certainly when you are undergoing treatments, the reality is radiation or chemotherapy is looking to oxidize or kill off those cancer cells, and then if you take high doses of antioxidants, the reality is you may be battling yourself and you may be actually doing yourself a disservice. So I do think it is very important to talk with your physician about anything that you are doing, and certainly talk about what things can be effectively used, what things may be best to put aside until you are in a state of full remission and there's no evidence of cancer there.
Part of the way that reason chemotherapy works is that normal cells can withstand the damage and recover, and the malignant cells can't recover as easily. So what we're saying is if you're giving, a super protective, dose of antioxidants, you're going to help the cancer cells, which with respect to the chemotherapy are more crippled than the normal cells. So, don't do chemistry experiments. Let your doctor know what you're taking.
We're almost to the end. I'm going to ask each of our panelists just to make one comment to the audience today and anything they'd like to say to the audience. Janine?
Well, certainly as a health psychologist and wanting to keep people healthy in the midst of a medical illness, I think one thing that I see and one thing that I found that the role of, having people take an active role in their health in any way, being an active advocate for their health, anything that we can do to help people get a sense that they are again, I think like Betsy said at lunch, taking an active role in your life and kind of our perceptions and our beliefs about, who we are, the world, the environment that we're in, how do we help ourselves to kind of take some control there? That can do a lot to help us be less distressed in a very stressful time.
Betsy?
I would simply reiterate what I said at lunch, but particularly for all of you who may be new to this journey, there is so much hope out there, and it's not just grounded anymore in just blind hope we make it. We have so much good science now that backs up that hope. And as I said to you, in the last 10 years, I have seen more advances. They are truly remarkable, and you've heard some of them today. Cure really is only a word. We really don't need it. We can live with this disease. We can put it in the past. So I would say to all of you, again, take charge of your life. Yes, some of us, or most of us, are at one point or another are going to have to go through some kind of a treatment, maybe 2, maybe 3. But you know what? There really is, just like I said at lunch, so much life with and beyond lymphoma. Live it.
Henry?
Good news is we have a lot of different treatment available for lymphoma, in particular for follicular lymphoma. Bad news is hopefully we don't make you more confused after today's talks. There's so many different treatment options. There's no one straightforward one, A and then B and then C. So it's very important with increasing treatment available that you have a team of doctors that are experts in the area that work with you, partnering with you and your family. Cancer not only impacts the patient, it impacts your entire family. And you need to partner with your doctor to find the best treatment for yourself. Everyone is unique and different, and we are towards, I still like the word cure. We're working towards the cure of follicular lymphoma.
Thank you. Chris?
Great. I'll just make one quick comment related to the last point about foods and other issues. We just recently worked on a paper with the International Lymphoma Epidemiology Society, or InterLymph, trying to discover or to look at what is known about the causes for follicular lymphoma. And we have a paper that should be coming out any day now that addresses all of those things that are known. To me, that paper is important for two reasons. One, in that we're trying to discover the things that lead to follicular lymphoma, but more importantly, the first author of that paper is a medical student that worked with me, Alex Ambinder. And his father, Rich Ambinder, is a very famous lymphoma doctor at Johns Hopkins. So we are now moving on to the second generation of lymphoma doctors and lymphoma researchers who are dedicated to trying to develop new strategies for uncovering why these diseases occur and strategies for developing cures for these diseases. And I think one of your roles and the role that you've heard about throughout the day is to learn more about the disease, learn more about all the potential treatment options, but to participate in clinical research and clinical trials where you can help to try and uncover new ways for curing this disease.
Thank you.
And I'd just like to add that the pace of research, and I've seen it in my own career, is staggering right now. And I can assure you that with respect to your lymphoma, the longer you survive, the greater the probability that you'll continue to survive.
Thank you. Again, thank you to our organizers, Liz McMillan. Thank you, Scott, and your wife, and to our wonderful audio-visual staff. Thank you very much, and especially our panel.